I want to tell you about my patient Mary. Mary was an atheist woman in her 80s with a narrow life view. She'd had a history of cancer, and that's why I had seen her. And there was a multi-generational history of relationship difficulties. She was always getting into arguments with her daughter, and her daughter was with her, and she had with her mother. And at one point I said to her, "I think you're from a line of prickly porcupines." And she kind of laughed. But I think it was really multi-generational depression, and they were all very rejection sensitive and perceived rejection very easily. So my therapy was eclectic. I tried to address pertinent medical, psychological, social, and spiritual factors. So I looked at the medical and mood factors. I tried various antidepressants in various dosages to decrease her sensitivity to rejection and criticism, because I thought maybe we're looking at a symptom of chronic depression if she's chronically feeling punished or persecuted. Psychotherapy focus included her childhood issues and helping her to develop some insight into her ways of perceiving herself, the world, and others. I tried to broaden her egocentric perspectives regarding relationship battles with her grown children. How would your daughter see this? Maybe your daughter sees it differently from the way you see it. I advocated for her at times in the clinic and tried to bolster her medical and psychological approaches to the physical challenges that she had, such as shingles pain that she had for a while. I prescribed a little bit of clonazepam, which really can be very helpful for those of you who are doctors. I encouraged her to broaden her social network. She said that and spiritually, I tried to encourage her to read and to attend a religious organization she had once attended because it had social advantages. She'd attended a particular organization, didn't hold those beliefs, but thought it was a good thing. So I said, well, maybe you should go back and try that. I suggested she read Life After Life by Raymond Moody. She wasn't convinced. So then I suggested she read about the experiences of children in Closer to the Light. I mean, we also talked about it. She came to her next appointment with a more open mind. She said, after all, children haven't been exposed to as much religious propaganda, but they even had similar experiences. Maybe there's something to this. Several months later, she was diagnosed in her 80s with metastatic illness, and yet she faced her situation with peacefulness and a new sense of serenity and of hope for her future that was nudged along by her new knowledge of near-death experiences. I couldn't believe the timing of that. I'd seen her for several years and had made little progress, but I felt that the timing for me to introduce the topic of near-death experiences was divinely led. You know, because I had no indication when I did introduce it that her cancer would return. It returned shortly after, and she died in a hospice a mere 2 to 3 months after the topic was initiated. And in those months, she was much more contented, more philosophical, and less angry than in the previous few years. She now had a greater sense of meaning and perspective for life's journey. She could see that there was a broader way of looking at things, and she was hopeful of the spiritual realm. So those are ways that we can use the stories in various contexts, when people are afraid of dying, have a fear of dying, when they're actually in a terminal situation, or when they're suicidal, or when they have feelings of a lack of purpose in their lives. And what are some of the other resources that we can help or encourage with patients? Well, I've mentioned the shared death experiences therapy. Sometimes they talk about reincarnation-based therapies. And we talked a little bit about afterlife offshoots with Brian Weiss. Linda Bachman also does work with past life therapy as well as Brian Weiss. She does past life regression and between lives regression. And in these past life regression therapies, basically they use clinical hypnosis, which is focused attention to attain a relaxed state. That's all that hypnosis is, by the way, for those of you who are nervous about it. It's just focusing on a singular focus and then letting other things go. And that's why it's very useful in pain management, by the way, because people focus on a trip to Hawaii, or they focus on sitting by the seashore or imagining the sounds, and they tune out all the other stimuli. So past life regression uses hypnosis to help people feel very relaxed, and then they go back and tend to spontaneously, with a little direction, recall past lives and lessons learned. Now, what about afterlife communication? This has been kind of a new thing for me in attending these conferences and learning about it. And I know Sonia Rinaldi from Brazil has been involved in this, in using electronic communication with other people, as tools or mechanism to receive messages from the other side. In this context, not just with Sonia Rinaldi's work, but I've had people say to me, well, my loved one or my spouse told me they'd come back to me after they died, but they haven't come back, and I feel very deflated. And my comment is that I think sometimes grieving relatives are sometimes so intensely grief-stricken that they're less likely to perceive the presence of deceased relatives. And I think grief maybe affects the ability to perceive spiritual energy. And I'm thinking along the lines of what I talked about, shifting that perceptual sweet spot of focus. Or maybe it dampens the functioning in the temporal lobe somehow. When you're depressed, you lose faith. And if you're depressed, what's happening? Are you dampening those anatomical structures in the brain, or the pathways involved with mood and spirituality? And I wonder if grief also affects those pathways. And so then somehow, if you're dampening the temporal lobe functioning, the right temporal lobe functioning, maybe along with dampening faith, maybe you're dampening the ability to perceive spiritual energy. Sometimes people have experienced that when their grief lessens, then they're more likely to have a visit from the other side. But I know I should be walking with tiptoes here, because you're the expert, many of you are the experts in this field, more than I am. And I've talked a little bit about Rochelle Wright's therapy, and my thoughts about that. So I've actually combined some of the talk from yesterday, so that's why I'm kind of looking at some of these slides with a little surprise. Now finally, I just want to address education. Near-death experiences are actually, it's like a taboo subject in medicine. It's not a regular topic in medical schools. It's not a regular topic in palliative care training, nor in psychiatry programs. It's unbelievable. It's not a regular topic in trauma or emergency settings, and it's rarely on the medical conference agendas or in educational rounds. So I know Dr. Fenwick spoke at the palliative care conference several years in Canada, but that is so rare to have that kind of acknowledgement. And why is that? I mean, it's quite shocking. I think it's fear that it could be politically incorrect to discuss religion or spirituality. I think there's confusion that a near-death experience is a form of religion. And in North America, it's like there's an allergy to religion. And so what I think we need to do is to explain that near-death experiences are they're psychospiritual events. They're experiences of people. They're not part of religious dogma. And I think that's the way that we can bring spirituality into the medical context, by saying it's a profound experience that has psychological and spiritual consequences. We need to acknowledge it. Our patients and our friends, our family are experiencing these things. We need to know as much as the general population does, and we need to understand these phenomena so we can help patients. So I was on the palliative care ward a couple of weeks ago, and I looked at the library they have there for the patients and the relatives. I was horrified. It was like, we will never recover the loss of Lucy forever, grief, in black grief, men's grief. And it was all about grief and bereavement, and it was sickening. And there was one book by Maggie Callanan about final words that people have before they're dying, along the lines of Christopher Kerr's TED Talk. But that was the only one. There was nothing for the patients themselves to be reading. I thought, my goodness, we need to have something uplifting here. So I think, and it struck me while I was there. I went to see one of my patients, and he said he was anxious, really worried. And I saw spiritual care had visited him, and they'd done some deep breathing, but that was it. And I thought, deep breathing, he's afraid of dying. We need to talk about near-death experiences with this man to let him know what people experience who come that close. And he felt quite relieved when I talked to him about it. But I thought, if I don't tell him, it's like malpractice. I mean, if I thought he had an infection and I withheld an antibiotic or didn't give an antibiotic, people might say, well, that's incompetent. So why are we not saying in palliative care situations it's medical malpractice or incompetence if we don't give people hope of what might be a possibility and of what other people have experienced? So I'm becoming a rebel. We need to teach the next generation of healthcare providers, and the recommended videos, the near-death experience, what medical professionals need to know by Roberta Moore, it's excellent, and Life After Life video by Peter Shockey, The Afterlife by Paul Perry. These are all good videos. And these are on the slides. I'm going to move along. And we need to teach the other healthcare professionals. Many healthcare professionals are totally naive about death and spiritual considerations and are left to come to their own perspectives on the issues, sometimes from a spiritual vacuum. Their perspectives are going to have subtle and not so subtle effects on how they persuade patients to come to decisions in facing situations, such as what I've observed to be subtle coercion to sign do not resuscitate orders, or to really promote medical assistance in dying. So, I mean, these issues are there. I mean, no one wants to admit that there's subtle coercion, but I've seen it. And we need to bring education to all areas. These are all different areas in the hospital: emergency, acute care, ICU, renal, cardiac units, surgical units, palliative care units, naturopathic clinics. But, not everybody here is a healthcare professional. We can all do our part in educating our friends, our relatives, when they're afraid of dying, just, talking about these things. And it provides a way that's not religious regarding whether you're a spiritist or how you approach things. It's a way that we can access it. So, I'm going to just finish at this point and say that one woman who was approaching death stated, "I feel a bit anxious, but then I'm always a little bit anxious when I start a new journey. And perhaps I should be, as Dr. Fenwick suggested yesterday, adopt an attitude of curiosity. I should be curious." Thank you very much.
We've got some time now for questions before our coffee break. So do we have any questions for Elaine?
Just bring them down, please. Quite a few.
Okay. Let me take the first one. First question. Should people on antidepressants for many years, should they change to a new medicine?
Well, if they're depressed, definitely they should change to a new medicine or have the dosage reassessed. But if people have been stable and doing well on it, then they might want to, and if there's a long-standing previous history of numerous depressive episodes or a family history of depression, they might want to go very carefully in considering whether they want to decrease it or whether it's helping them cope as it is. What I often suggest at that point is just to taper it down a little bit and very slowly and see how they do. And if they're fine after a month or two, then taper it down a little bit more and do it very carefully. After all, the body has probably readjusted to a new equilibrium by having that medication, and you don't want to trigger a rebound by stopping the medication too quickly. But some people actually are on antidepressants for many years and they cope well with that.
Okay.
Oh, did anybody hear any of that?
You speak very clearly. I don't think you need a microphone at all.
But you're 10 feet away.
Okay, next question. It's an interesting question here. From a person who would like to know, do you have any idea how many people in the audience have the phenomenon of hearing voices or see discarnate spirits?
Okay, yes, I'd like to know. How many? I suspect it's even higher.
How many people in the audience have had the experience of hearing voices or see discarnate spirits?
So that's pretty...
So whoever asked the question, have a look around, please, and count those hands.
And does that answer your question?
And how many have had a near-death experience or have had an out-of-body experience or have had someone close to them who has?
Wow.
Yeah. It's common, yeah. And yet it's not talked about that much. I do want to caution people that some psychiatrists are open, like Dr. Rediger, and hopefully myself, but not everybody is. So you have to be careful and use your intuition in who you tell what. Because I don't want people to go off and say, okay, it's a new era and psychiatrists are more open, and then get hit, tell somebody who's not really open, and it creates problems. So I'm just concerned for everybody's safety.
Thank you. I'm not sure, I've got a question here for Dr. Elaine and Dr. Filippi. I'm not sure if he's in the room any longer. Please describe similarities you have found amongst people who experience out-of-body experiences as a child. For example, do you find that they have greater spiritual awareness, more relaxed, or more stressed? Is there any patterns there?
Well, I would think that people who've had out-of-body experiences in childhood or in adulthood would be more open to the sense that there's a spiritual realm, or that they don't identify their souls as being totally tied to their bodies. I mean, I guess that's evident, but I think they would probably have a more spiritual sense of their identity. I think it's very interesting, the number of people who've had flying dreams. How many people here have had flying dreams where look at that. They're so common. And yet, I mean, psychiatrists don't know about them, but I remember one, I just loved it, flying. I thought I was in a hang glider flying over the western part of Calgary. And then I've had helicopter dreams where I felt that I could angle up. And I remember in one dream saying, oh, don't think that you can't do it. If you think you can't do it, you'll just drop. So, but they're very common, as evident in the room today.
Next question. People generally seek new drug trials or groundbreaking treatments as a means to reach cures for terminal illnesses. How can we incorporate a spiritual approach as a viable option to heal a dying body?
Well, I don't see them as being mutually exclusive, generally. I think people do much better with hope, and sometimes people feel hope if they have another consultation, see somebody else, and they learn of something that they could try. We have to be very careful, though, that people don't get taken in by clinics that are willing to prey on people who are willing to pay tons of money for a cure that's very unlikely. But other than that, I encourage sometimes people to get a second option. I had one patient who left the clinic, and she was supposedly terminal, and 6 years later I bumped into her at a conference, and she said, "Hey, Dr. Drysdale, it's me. No, you haven't seen a ghost. I'm still here." Well, she had hope. She sought a second opinion, and she tried something else, and who knows whether the faith that the other medication would work. I mean, faith, belief is a very strong, powerful trigger for healing. We know about the placebo effect as well, and the placebo effect is like an amazing thing. It's the sense of that the body can heal itself, or belief that the body can be healed. So it's very complex, but I suggest that patients do what they can medically, and I also suggest that they do what they can spiritually, whether that's going to their church service, seeing their pastor or rabbi or whomever, or go to prayer services or 12-step programs I encourage. And by the way, 12-step programs are interesting. The first step is considering the possibility or feeling I can't control the situation. The second is maybe there's a higher power or spiritual being, and the third is asking for help. And I think asking for help is a very key spiritual force. When you look at a lot of conversions, it's when they've asked for help. And I'll tell you, I ask for help every day. When I'm with patients, I'm with a patient, I say, man, I never learned how to deal with this in medical school or in psychiatry or in conferences or lectures or reading since. This is a unique situation. What should I say? And then the words pop into my head, and the patient will suddenly say, how did you know? That's exactly what I needed to hear. Well, it was the divine helping me. So I frequently ask for help, and that's when things usually go the best.
Thank you. Okay, so next question. What are your thoughts on natural alternative antidepressants? Then the person goes on to mention a few, St. John's work and Triopan, and their effectiveness.
Tryptophan?
Yes, and their effectiveness.
St. John's wort is actually a selective serotonergic reuptake inhibitor, so it's a mild form of most of the SSRI drugs, such as citalopram, escitalopram, fluoxetine, fluvoxamine. So it's really just a mild version, and it has side effects. There's drug interactions with it. There can be really bad drug interactions with it, and you don't always know the dosages that you're getting. So I tend not to suggest that with patients, because particularly as I work in an area where patients are taking so many other drugs, and I don't want to have drug interactions, and I've seen it happen. So, and the other one is tryptophan.
And just their effectiveness in general.
Tryptophan it's sedating. It's a precursor to serotonin. So, I've had one patient, actually the son of a patient, who was taking massive doses of tryptophan in a product, and he's been having terrible times. I think he's getting intoxicated with it, and then he's going through withdrawal from it, and he's having muscle problems, and I've had major problems with the hospital he's not directly my patient, but trying to get him admitted to the ward and having this dealt with. I'm sure that this is what's causing his problems. And by the way, just because something's natural doesn't mean that it's healthy. I mean, I remember as a resident being in Emerge, seeing someone with anxiety and heartbeat irregularities, and they'd had a lovely foxglove salad and had eaten massive amounts of it. Well, foxglove is the ingredient for is basically digitalis, which is a heart medication, and if you take too much, you're going to have problems. So, I mean, things can be very natural, but very poisonous too, if you take it in the wrong doses. And for some things, the correct dose would be 0.
Thank you, Elaine. Next question. Could you say a bit more about working with fragments of experience? For example, like that creature that crawled up your leg.
Thanks, Mick. Mick and I were talking about this and wanted to ask about it. So I mentioned earlier about having a sense of, at one point, having this reptilian creature. I was wide awake in this bed and just feeling like my dog used to walk on me, and it felt like that. And I thought, my goodness, I'm not mentally ill, I'm not septic, what's going on here? And that's when I prayed, and then it disappeared. And it reminded me of another time I was doing participating in a workshop with Brian Weiss, a psychiatrist who does past life regression therapy. And he does a common experience, little session with people where he has them go into a trance, get relaxed, and they imagine what shoe they're wearing on their left foot, and they look down. And I looked down, and there I was wearing a left pilgrim's brogue that belonged to a man. And I thought, this is like a Dutch brogue from a pilgrim. And I thought, wow, this doesn't seem like it belongs to me at all. I don't think I've had a life as a male Dutch pilgrim. And then I thought, this is very strange. I've had lots of memories and experiences with previous life and memories throughout my life of a past life in Vermont, and I'm familiar with that, but this seemed weird. And then I thought about it. Where was I? I was in upstate New York, and New York used to be called New Amsterdam, so it was Dutch pilgrims, and I was presently at that time in the town of Rhinebeck. And I thought, oh, I must be picking up a thought fragment or something from somebody that was here. It felt like I'd been going through the dirt and picked up a pottery fragment. And I thought, it was like saying, well, that pottery fragment never belonged to me. It's just here in the dirt. And I felt like throwing it away. It was just a fragment I picked up. And I wondered about that reptilian feeling that sense I had of a reptile crawling up me. Was that just something from dinosaur eras gone past on the same property, or was it some evil thing? So we don't know. I'm not an expert in reptilian energies, so maybe it was an energy, but it also got me thinking about thought fragments that we could pick up from previous energies and lives.
I think the term you were looking for there was reptilian interdimensional species.
That's what I meant to say. Thank you. Reptilian interdimensional species.
Thank you, Elaine. The final comment here before the coffee break, and Ellie has something to say, but the final thank you for Dr. Elaine comes from a member of the audience. Says, thank you very much for such an inspirational talk, and also thank you for teaching us caution.
Oh, good. Well, I hope that I have taught both caution and courage. And I look at people in the room like Dr. Fennick and others who've been very courageous in moving forward and in sticking their neck out at times, and that has forged the way for others to come forward. So I hope that I leave you both with thoughts of caution and courage.
Great. Thank you very much.